Recently, a group of osteopathic clinicians and physical therapists and researchers have been speaking out in osteopathic journals about some of the issues existing in osteopathic practice. Now, don't get me wrong, these issues exist well beyond osteopathic practice. They exist in physical therapy practice, they exist in chiropractic practice. This week's guest, Diego Hidalgo, is a trained osteopath and physiotherapist, and him and his colleagues have been raising concerns over these dated theories and their lack of scientific plausibilities. Diego and I talk a lot about their paper around anatomical possibilisms and some of the challenges that brings as far as better helping and understanding those people in pain. I think you're going to enjoy the episode. There's a lot of great discussion points that Diego brings up, and I think you'll get a lot of value out of the episode.
This is the Modern Pain Podcast with Mark Cardula.
Welcome to the podcast, Diego.
Thank you so much, Mark. Thank you for having me here today.
Awesome to have you. We're going to get right into it today because your paper really caught my eye. I work in an osteopathic college in DO training and here in the US. And we'll probably speak to that, the differences about, osteopathic training here in the US and maybe what we see in Europe and abroad. But let's get into this discussion and let's talk about the paper you had here, because the paper I thought was a great paper. It brought up a lot of concerns I've had within physiotherapy practice. So by no means are we throwing rocks in glass houses here. Physiotherapy has its own issues with what we're going to talk about, anatomical possibilism. And I know you're a physiotherapist yourself, and you're co-authored this with some osteopathic practitioners, I believe, over there in the UK. Can you speak to a little bit of what's meant by anatomical possibilism when it comes to what you discuss in the paper?
Sure. Anatomical impossibilism or possibilism is kind of a framework that has been used for a long time to make sense of the things that we have been seeing on clinical practice. We have a lot of gaps in our reasoning as physical therapists, osteopaths, chiropractors, and we have tried to fill those gaps. In the paper, we talk about the God of the gaps. We have tried to fill those gaps with the models that make more sense. And in this case, it was anatomy. Anatomy has been the hard science that has identified us and kind of opened the mainstream medical field for us, because before we were kind of something like massage therapists. So in that sense, I believe that we have used anatomy to create a lot of our reasonings, and many of those reasonings have kind of turn against us. They have kind of created a revolution against us. But in the time that we were promoting anatomy as our cornerstone, it has been key to give us a place within the medical field, the mainstream medical field.
Yeah. No, I think anatomy has been such a cornerstone. I know in my physio training, it was huge, and I think it's been put in perspective. And your paper, I think, nicely brings up a lot of the discussions of why we need to put anatomy in perspective, just because of what science and what our understanding of pain and everything talks about. The paper, for those of you who are watching here on YouTube or listening on the podcast, it's called "It's All Connected, So It All Matters: The Fallacy of Osteopathic Anatomical Possibilism." It's a tongue-tying title there, but
yes, as we did it on purpose.
Yeah, exactly. You made it hard for these podcast guests or hosts here to kind of get through it. I'm wondering, we had Ian Harris on a few weeks ago, and obviously a very prominent Australian osteopath, orthopedic surgeon, who really spoke to some of the issues that he faces in his profession. One of the big things is this pathologizing of normal, or this medicalization of the normal. And in your paper, you all talked about pathologizing imperfect features. And I remember coming out of school, and even in school, I was trained with osteopathic principles. I took some continuing education where it was very osteopathic based. Michigan State University was very close to me, which is a very big osteopathic manipulative medicine hub here in the US. So I was very deeply trained in it for an extent. But can you speak to what you all mean when you talk about the pathologizing of the imperfections and kind of the issues we have with that within not just the osteopathic practice, because I think it exists across different professions?
Of course. So we have chosen osteopathy, but osteopathy is just what we believe is the peak of this model of reasoning currently, but it applies also to every other profession in the musculoskeletal field, including also surgeons. So the thing with pathologizing what's normal, or what we call ugliness, is that when we study, we use textbooks that show us what is considered as the perfect human. So kind of similar, for example, height and how do you mean wingspan? Yes, wingspan. We talk also about how perfectly should all the vertebrae or the bones look, how all the muscles. Many times the textbooks kind of use like bodybuilders to show what should anatomy look like, and that's like that's the 1% of people that we see in clinical practice. So when we talk about pathologizing ugliness, we mean that we have seen over and over and over again that during many MRIs or during many, let's say, physical explorations, we have found things that didn't look like those textbooks. And because there was a friction between what we are taught is the perfect thing and what we are seeing in clinical practice, we are thinking, okay, then that's the cause of the issue. If we apply this to, for example, surgeons or surgery, we can see how this works, because if we go to place A, because place A is in pain right now, and we find something that doesn't look like textbook that we have been shown, of course, we will say, if the issue is here, it's because of this structure, and I need to change the structure to change the pain. So we have inherited this model or with this way of thinking, and we have done exactly the same in osteopathy or physical therapy. The thing is that we have also, and that's the possibilism part, we have tried to establish connections that sometimes were quite absurd, because I can understand that you have a patient that has, let's say, a bone that doesn't look like it should. And we say, okay, you should have this checked out, or maybe have an x-ray to see if there's something weird going on, like a luxation or something like that. But we have tried to say, okay, you have pain in your wrist, for example, because there's a structure B that is located on the contralateral shoulder that doesn't look like it should, or it's not acting like it should. For example, osteopaths have these kind of tenets, and one of those tenets is that the structure governs function. So the way your structure looks will lead to a better or a worse function, and many or most of the treatments that I learned, because I'm a physical therapist, but I also have formal education, college education as an osteopath, they will say, you need to change the structure to change the function. So if pain is the issue, there's a structure that is not working or doesn't look like it should. We are talking here about, for example, a misaligned back, or a bone that doesn't look as perfect as it should, or for example, a shoulder that is slightly higher than the contralateral one. So yes, when we are pathologizing ugliness, sometimes or many times we are pathologizing human existence, because all humans are imperfect. Asymmetry is the norm in humans, and we try to perpetuate this bias. We don't do it on purpose, but we are making a lot of patients feel like they have something wrong with them in the terms of a structure, that they need to have a surgery done, for example, to correct some things, or that they need to go to a chiropractor 2 or 3 times per week for the next years, 10 years, 20 years. So there are perverse incentives that in part they are intellectual, and in part they are about money. But I believe that we can do much better, and we can do it not due to common sense, but not necessarily due to common sense, but we have the data. We have a lot of clear data showing us that, look, things don't need to look as perfect as they look in a textbook to work perfectly fine. And we are seeing, for example, how people with, I think that it was last year here in Spain, there was a cerebral palsy patient that finished a marathon. And that was kind of a change of paradigm for many, because they said it's impossible that something with a cerebral palsy can finish a marathon, because their structures are completely, let's say, destroyed from a cognitive or from a neurological perspective. And even with those barriers, he finished that, showing us again, because we see this every time, showing us again how resilient the human being is, how many things we can do even if we don't look perfect, how many variability there is within us, within many really common and mundane movements like walking. We are seeing this every time again. And we are trying to convince people that they are breathing wrong, that they are walking wrong, that they are eating wrong, that they should sleep only using 35 pillows, all placed in a very specific order to correct any kind of imbalance. And many times what we are doing pathologizing that ugliness is pathologizing the reality of most humans, because nobody lives in the way that these people want us to live.
Yeah, you bring up some good points. I think it's that whole osteopathic, and it definitely, I remember it very clearly in physical therapy school, this, structure equals function. And that was where our theory on pain really still lied. I mean, I remember in PT school and physio school where we'd get a little bit of the gate theory, but it still was very much revolved around the periphery, right? And there's so much human error and bias that goes into, if you conceptualize that everything exists in the tissues, when you go looking in the tissues, you're going to find things. And you nicely bring up some of the normal asymmetries and anatomical anomalies. Like we learn this perfect, human structure that's got all this symmetry and things. I remember, and I've talked to numerous anatomical colleagues, and they kind of chuckle at it. Like, do you remember when we had a dissection or your cadaver lab in anatomy where we saw real. And there was, asymmetry was the rule. It wasn't, something where these folks were perfectly symmetrical. Yet we still have a lot of these theories that have us stuck in the tissues. And as I've said, it's osteopathic practice is kind of the example here, but it exists still. Chiropractic, physio still has some big issues in moving through that. When we think of the modern understandings of pain, obviously it's gotten us past structure. Doesn't make us throw out structure, because that's usually the big argument that gets thrown back. Well, you're just saying we just talk to people and we don't move. I think it de-emphasizes the necessity of perfect structure, and you brought some good examples up. I'm just wondering where you see kind of current definitions of pain and current practice patterns out there. And maybe obviously in your paper, osteopathic profession's been identified, but in physio, it's similar. Physical therapy, same issues. I'm just wondering where you see some of the disconnect with current understandings of pain, modern pain theory, and what you're seeing out there in clinical practice.
Of course. So, for example, in the IASP definition of pain, they talk about potential, a potential threat that may be producing that nociception that then leads to pain. So there's a class because we never take for granted the potential part. For us, always there's something going wrong. There's a structure that needs to be fixed in some way. We may not take into account many of the psychosocial issues, and many times when we are trying to deal with these pains, these pains, we are kind of forgetting about many times the pain. What's pain? What really pain is? We are trying to constantly throw everything at pain. I think that the expression that you use is throwing the kitchen. Like all the tools, you want more tools because you have seen that this pain is not healing. So you need to buy new courses, try new techniques. You need to always keep doing things to people instead of doing things with people, trying to let the pain subside in some ways. We are seeing how many of the conditions that afflict the musculoskeletal field are self-limiting in nature. So natural history and regression to the mean are important allies, sometimes enemies in the case of, yes, certain conditions, but not most of them. Most of them have a favorable prognosis. And we are trying to find someone that's guilty and make no prisoners then. Like we are trying to destroy the things that we believe that are wrong. And of course, there's a contradiction between the models, between how the biopsychosocial model or the definition of pain is defined. Yes, how pain is defined and how we are practicing in our clinical reality, because we are always trying to make this passive care that doesn't take into account much of the individual. The individual is thrown at a treatment table. We start throwing them things to see what happens. Nothing happens. The patient starts to feel powerless. We keep saying that there's something wrong, that we need to fix it. If we don't fix it, we will send them maybe to the surgeon or to a colleague. And Of course, sometimes we will kind of justify our approach because we will see those quote unquote miracles. So then after treatment number 35, the patient will feel much better. But maybe what we are doing is fooling ourselves, because we are saying, yes, after a year, the condition has improved a lot due to all the treatments that we have performed. But the reality is that maybe it was natural history. The patient has spent a lot of money just to experiment all the things that we can offer. And many times self-management is a key option that we may not propose enough, especially because, I think that this also varies depending on the culture. There are certain cultures in the world that are more individualistic or collective. So I will expect for someone that is quite individualistic to say, okay, tell me what I need to do, because I don't want to be coming here every day and it's a bit of pain, and I'm fine with that. It's kind of related to self-efficacy, but there are other persons, maybe depending on the demographics too. Maybe it's people that are older adults, for example, that say, no, I want you to fix this because I don't feel comfortable dealing with this alone, or I don't feel even comfortable dealing with this. I want you to help me or to heal me like the doctor has been doing forever.
You bring up the thoughts of regression to the mean and natural history of conditions. And I remember personally, that was a tough thing, because I think there's this sunken cost we all have as professionals where we're trained in, and I went down the manual therapy. Those of you who listen know my journey with manual therapy, that I would, more letters, I got to have this. And I really self-identified with it, to the point when I heard some of these narratives coming of, well, maybe it's just natural history and you're just hanging out with the natural course of the condition. Or, hey, yeah, when people come to see you, their pain's usually at an up, at the peak of its, nastiness, I guess you could say. And it's got usually one way to go. It's going to improve. And that just was too hard for me to consider early on in my career, to where, well, it's got to be me. I mean, I want to feel worthy. I want to feel like I belong. I want to feel like I'm making a difference. And I still think we can, right? But it needs to be under some, solid scientific theories, and then maybe again putting patients more in the driver's seat. Because this brings me to the one concern I have, and I'd love to hear your thoughts on it as well, as medically unexplained symptoms. And anybody who works with, pain will get patients where they've been through all the testing, all the ologists out there. I used to work at the Mayo Clinic, which is one of the world's most preeminent medical facilities out there. And I'd see people go through all the ologists and, just note after note of all these folks and well-meaning folks trying to see, okay, is there something I can identify within my little categorical understanding of the human body and pain, and see if I can help this person. Oftentimes that might cause a person to get 15 different diagnoses. Sometimes they'd still have medically unexplained symptoms where there just wasn't that thing. And again, when we look at pain, it's kind of makes sense as now we understand that there's just so much that goes into it, to expect to put one little like nice, neat, tidy label and things on this, when we know there's just such a whole complex mass chaos biopsychosocial entity that emerges from a person and their unique pain experience, almost like the unique fingerprint that we all carry. Yet we want to put it in this unique bucket. Bringing this to this thought of anatomical possibilism, I just worry that those folks when desperate for a diagnosis and desperate for an answer, that there is not any, and it seems like they are easily able to grab onto something where there's a very, elaborate story of, things that don't have much scientific basis, of cranial bones and SI joints doing a bunch of different things and things that, again, not me, personally, but science is telling us that this isn't the way the human body works. Do you worry, or do you have concerns that there are patients that when they have these complex cases that they can easily fall into, and not just with osteopathic, because I know physical therapy and other there's no shortage of stories that can be thrown at people to get them believing that I found the thing. And I see people with chronic pain who've been through all the latest things with chiropractors, osteopaths, physical therapists, and things. Can you see the issues that would kind of coincide with this anatomical possibilism and maybe the ability to give some people that may just need a more self-management, I need to take ownership and not try to find some new fix for this thing. I need to start working back into life and doing things we're going to get pulled into this anatomical possibilism type approach where we can make elaborate stories of elaborate ties of anatomical structure, devoid of a lot of scientific backing, that these folks can get stuck in that?
Yes, of course. So there are two papers from the same group. I think that it's Tammy Hoffman. They published two papers about the expectations of both physicians and patients about what the benefit and the effect sizes of the treatment they were receiving. What do they think? What did they think about it? So I call this the dictatorship of good intentions, because clinicians want to help patients as much as possible, and patients want to be helped as much as possible too. So because it's a reciprocal connection, we are seeing how this clash between the both sides is kind of showing up on the clinical basis, on the clinical reality on a daily basis. And it's, of course, I understand the needs that both sides have, because they, for example, for chronic pain patients, they want to believe that there's a cure, that there's something that they haven't tried yet that will heal them and take them out of the miserable times that they are experiencing. And clinicians want to feel appreciated and want to feel kind of, let's say, valued by society. They want to feel the role that all that society impose on them. And they may try to reach those connections. They may try to find those, let's say, those anatomical impossibilities, and they will try to try things, hoping that some of them work. So, of course, for chronic pain patients, what we are seeing is that most of them are not recovering quickly, many times because maybe we are not asking the right questions. Maybe we are not seeing the red flags, and we should maybe ask a rheumatologist, for example, to give them a check. Maybe that's a rheumatological condition. Maybe that there's a fracture, or yes, a stress fracture too. So we need to clear those red flags. And after that, we may be dealing with things that escape our abilities. Maybe currently pain is still a mystery, and it's not easy to deal with it, especially when the symptoms are quite vague. When I say vague, and I'm not saying that in a pejorative term, but what I'm saying is that, of course, if the only symptom that you have is pain, it's quite hard with our test to be able to diagnose and specify what the pathanatomical structure is involved with it. Then we send them maybe for an imaging test. We see how everything comes clear. And the thing is that patients want to have something wrong with them, because the uncertainty of dealing with something that seems totally fine is quite. It's a horrible experience for both sides. Of course, for the patient that have pain, but feels that there's nothing wrong with them, or that people may not believe them because there's nothing wrong. Because of course, if you broke your arm, people is going to be quite they are going to understand a lot because why you have pain. But if you have chronic pain, many chronic pain patients talk about this, about not feeling part of the society or their social circles, because they are constantly being accused by society as a whole that they are faking or pretending. And that leads to a lot of frustration, powerlessness, depression, of course, and many psychosocial issues that are both modulating the symptoms and on the intensity. So yes, I believe that anatomical possibilism in part has been conceived to deal with many of those strange cases. And from 1,000 anatomical possibilism reasonings, if one of those reasonings kind of click and the patient starts experiencing much better for reasons that may not have to do with the treatment itself, that person is going to, both the patient and the clinician are going to spread that as a rumor, because people want to believe that there's a fix for them too. So if one has a fix, the rest may have a fix too. We may see in those ways the birth of a new guru, for example.
Yeah, you bring up some great points there. Society, especially societal challenges that a lot of patients face with, not signaling to society that they're in pain, because chronic pain can be one of those invisible diagnoses as far as it doesn't often show on the surface. You might see it in people's movements and their facial expressions and things, but again, they're not in a wheelchair. Sometimes they're not in, have a cast or a neck brace on that signals to society that, hey, this person's in pain. And unfortunately, that does equal a lot of horrible experiences and a lot of invalidation that some of our chronic pain patients deal with when they're trying to navigate a very massively difficult situation, and then a society that they're trying to exist in that's not very validating, that's invalidating, that often can be downright rude and nasty to folks that are trying to do as best they can in the circumstances. When it comes to our understandings of psychosocial trajectory, this is the thing too, when we see studies, there's always a Jarvik study, and I'll link it in the show notes, that I think it was a 7-year, 10-year study where it looked at MRIs on the baseline of a big, pretty solid group of people. And then I think it was either 7 years or 10 years out, the people that had pain, they went back and looked at MRI studies in hopes of seeing, okay, well, what are the imaging findings that would predict these people that develop pain in this time span. There were some mild, associations with MRI findings. Yet the biggest association was depression. So these psychosocial components being massively predictive. I'm wondering what your thoughts are as far as when we get people so tied in with anatomy, and I can definitely reflect upon this in my own practice. I discuss my position as a reformed movement jailer, as far as I used to get people in this movement jail where you can only move a certain way. And when we get people in this mindset of just very frail anatomical structures that are in and out of place, to me, and I see it on a regular basis, where these people have zero locus of control over their symptoms. When this mythical out thing happens, they have zero control, because it's not till somebody can put it back in that they have control. And I know a lot of our osteopathic and chiropractic colleagues and physical therapy are as frustrated as anybody that exists, but there are still a lot of issues when we use these theories that kind of are formed on anatomical possibilism and things. Where do you see this influencing people when we're looking at psychosocial behavior, like how people think and behave around pain when they're engaging in care that's formed on some of these less than ideal theories?
Yes, so of course, humans are embedded within an environment, and that environment goes far beyond their own body, because they are constantly interacting with many humans, including their family, their friends, their peers, their bosses, society as a whole. Apart from that, of course, they have some interesting or some things that can modulate and that go beyond the biological, because they may be in an environment that may be a lower socioeconomic class. For example, we see a lot how patients that has that background tend to do worse than those who came from more, let's say, high class standard. Yes, and the thing with anatomy is that is something that is physical, that you can palpate, that you can see, that you can approach in ways that seem very, very logical. They seem very logical because you can touch the structure. There are certain things, for example, you cannot interact with the mind. You can interact with the brain, but not with the mind, for example, from a clinician perspective. And of course, anatomy seems to be the bridge that connects both the desires of the patient and the certainties of the clinician, because the clinician is very, very much into anatomy. It's his bread and butter. And patients, all of them, are completely open to believing that what is causing their pain is something that is completely physical, that you can pinpoint perfectly, that you can say, okay, the cause of your pain is here. Or it's maybe not in a given muscle or bone, maybe it's the way in which you use that anatomy, then we are entering into biomechanics. But maybe the issue is not that you have an ugly looking bone. Maybe the issue is that you are walking in a way that is changing the load patterns that you should be experiencing, and because you are changing those loads that should be the standard way, now that's causing your pain because you are overloading certain areas. Of course, that's an explanation that can be logical, because we see, for example, in ACL patients how there are some interlimb and intralimb compensations during the post-operative process. And we see how certain areas may be under load because others are taking control of the stuff, for example, with arthrogenetic muscle inhibition. But in the case of, let's say, the average orthopedic patient that has been walking the same way for 50 years, how much of the blame is to be put on the way he's walking? Sometimes I have runners that may say, look, I've been running for 30 years and maybe there's something wrong with my cadence. Maybe there's something wrong with my stride. And I think, and then sometimes I ask them this question, that why do you think that the way you run is wrong after 30 years if you haven't had any issue related to this before? And they will say, no, because I've been checking some YouTube videos and they are always constantly blaming this structure. And now, before I was trying to deal with the pain in my own way, like ignoring the pain, but because the pain hasn't settled yet, I've started to seek for help. And that health has become, I've seen so many, let's say, famous YouTube channels that are telling me, from people that seems to know their stuff, they are telling me that I'm running wrong, that I should change out of things. And look, they offer some new shoes, or they offer some treatment or some biomechanical analysis that I believe that it can fix me, but they live too far from my place. So I believe I would like to try that. Let's say biomechanical, bioanatomical stuff to see if it works. And many of those times we can deal with that with self-management, because many times the issue is not the way you are doing things. Maybe it's the intensity in which you are doing those things. That quote of sometimes the issue is that you are doing too much too soon. Maybe it's that you are overloading. We are ecological beings. We are interacting constantly with things, and our capacity is constantly changing. It's normal that some days we feel better or worse physically or mentally than others. And we need to deal with that. We need to understand why those things happen, what things are within our control, but also admit that many times we live in a world that is constantly interacting with our body. And there will be emergent elements that will emerge and that are going to escape our reasoning, escape our control. We are not going to be able to diagnose them or detect them, because many times we don't really know what's happening. But many times what we're seeing is that those things stay for a while and then they leave. How many times we wake up with pain in our neck and the next day we are totally fine, and we haven't had any kind of trauma, any kind of issue that could justify that pain? But if we ignore it, we are seeing that the prognosis is quite favorable. But we are also seeing that if we obsess over that issue and we start trying everything, we may develop a lot of anxiety. In the way we will lose our autonomy, because we will be told that we need to experience that. We need to become passive subjects and go to a clinic, pay a certain amount of money, and then experience those treatments. And we will, if we have success, again, we will say, okay, that was because of the treatment. Because if it was not for the treatment, there was no reason to justify that, because people don't know about natural history. They don't know about regression to the mean or other statistical phenomena that may be affecting their pathology.
Yeah, you bring up great points around it. I think there's a cascade of events that can happen when people get some of these labels and some of these things that convince them, especially in the presence of, to me, when we think about the misdirected problem-solving model that a lot of our psychology colleagues talk about, and where when we get people that oftentimes the research supports, it's more the dysregulation in their life that's surrounded this pain, this depression that's emerged because their life's been shrunk they're lost their identity, all these things that our patients tell us in their stories when we actually give them time to talk and listen to them, that it's probably those things driving it. Yet what we do as a healthcare system, because we don't honor that psychosocial piece, and you spoke to it very well, that all of a sudden now, instead of us pointing the problem of like, hey, let's get your life around these symptoms better, and of course do things that can help physically, movement things, all the things you mentioned as far as maybe some of the loading, adaptations and things to help people a little bit more adaptively move and engage in things. But when we fail to kind of, identify or help people make sense that it's probably more than just the alignment of your pelvis in static, standing position, or how big the part of the PSI drops in a stork test, or whatever it may be that we tended to do in the past, that we get people trying to solve a faulty anatomy problem for a faulty life and a bit coping and a faulty ability to continue to pursue of valued activities in our world. I just think it gets to be frustrating, and I'm with that frustration we have with and again, I've been the clinician I speak of, the person who used to put the movement issue or the anatomical things of these are why you're not getting back to it, and not even given their narrative or their story a stage. And because I had no idea how it tied into things when I was just focusing on the structures dictating all the function, and that was my sole pursuit. That's a tough switch for a lot of therapists to make, and you've mentioned some of the things already as far as like our identity, our value to society, our justification of all the horrible events and stressful things that we go through in university when we're trying to accomplish, becoming an osteopath or a physio or a chiropractor or things like that. With that challenge to make that switch often comes reactions that aren't always the most pleasant from folks that are not ready to make that switch. I've probably been that person when people were questioning my traditional beliefs on manual therapy, as far as, that it wasn't all about me Jedi hand skills and development of all these amazing skills. I'm not saying again that there's not some value in being good with your hands, but obviously we've overemphasized it. With that said, the reactions that you've received, I've read some of the responses to this article and others. Your co-author, Oliver Thompson's kind of co-authored some other papers around some of the challenges, and I think constructive criticisms on maybe where osteopathic profession in particular needs to kind of move forward. What has been your experience, maybe within your professional circles, be it via journal responses and things like that, but also just in general on social media and things, when you start discussing some of these papers and things, what's been the reaction you've received, and any of it surprised you at all?
Well, I think that I need to divide the responses that I have received, because I believe that because I'm embedded within this echo chamber of people that are evidence-based, and there have been a lot of great responses. I will say that the majority of the responses have been very, very positive. They have told me how much this was needed, how much we should talk about these issues, and the lack of papers that are kind of examining these issues from a critical perspective. Some others, a few, but just a few, say that we are trying to destroy the profession or the value that we provide to society, or that we are trying to get revenge because we don't like certain things, or we are bad with our hands when it comes to hands-on treatments, or because we want to impose our paradigm of exercise, or because we want to, I don't remember who said that, but it was something like, yes, of course, because a lot of people like you are trying to build their telehealth practices. It's you need to support the idea that manual therapy is not special, and that those that are currently doing manual therapy are doing something that is giving patients subpar results compared to exercise. And the thing is, what I would like people to understand is that, of course, the body is really complex, but because it's really complex, it's not that easy to let's say solve. We are not like a puzzle that is lacks the last piece. Our body is great at regulating things. If we have issues with our anatomy, for example, we will be able to deal perfectly with them most of the time. We are seeing them, for example, with scoliosis. but the responses have been usually the same things, the same themes that have been reoccurring time and time again. Because when you read the criticism that have been made, they don't evolve. They don't evolve with time. They are always the same things that have been said. And the sad thing is that we need a critical majority to change the field, and the changes that we will need to undertake within the field to change things and to adapt to the current times are going to ask us to make a lot of sacrifices and to rethink the way in which we approach the clinical encounter, because the clinical encounter is changing, and is changing quite fast. If we are not open to change the way in which we are responding, we will not be able to deal with the question, because the questions have changed. For example, I was thinking that osteopathy was founded on 1874, and we are trying to use many times the same reasonings, the philosophical principles, let's say, that Taylor still proposed. The same can be said, for example, for chiropractic and David Palmer philosophies. Both of them are quite related. And the same can be said, of course, from physical therapists. I believe that physical therapists are a bit more advanced in this reasoning currently. Not much, but they are, let's say, a step ahead in this discussion. But I believe that many within these three professions are still working within this paradigm that needs to be changed.
Yeah, I think I would agree. I think, and I'm of course biased of my opinion that physios are a little bit ahead of the curve. I mean, there's still examples of very dated ways of kind of thinking, and you bring up some great points of we're still working with theories that were back in the 1800s it's not to say that theory can't. I mean, there's been theories that have proven true. I mean, some maybe not to the 1800s, but it's a lot of Einstein's work and a lot of really smart people's theories carry on today. It's not to say that we're just disregarding their work, but when science is kind of staring it square in the eye and saying, we need to double think that, it seems like, and it probably becomes a little bit of a clinical comfort zone, and it's a very destabilizing experience. You mentioned how the clinical encounter is changing. We need to change with it and understand. I mean, I think it's the same things that we're dealing with, but our conceptions and our ability to kind of pull pieces together beyond the tissues. One thing I've always appreciated about osteopathic theory is this thought of interconnectedness, right? This thought of holism, of being able to look at the whole picture. The problem is the whole picture isn't just connecting dots within different anatomical structures. We need to be able to put in the whole of the person's psychosocial existence, society around them, social determinants of health, all these various things that we know have great impact on their trajectory when they're encountering a pain experience. I want to maybe wrap up the podcast with one last question. You spoke to it a bit, but where do you think we need to go to help clinicians? Because you're never going to change anybody, right? And say you're doing it wrong, you need to do it this way, because that never works. I'm wondering what you think would be ways to maybe help, because social media becomes this this very dichotomous, and oftentimes can be nasty, where people are, getting, very polarizing opposite end discussions, and there's rarely a middle ground that gets discussed of okay, well, what can we pull from some of these dated theories? Because there's, maybe some pieces that make sense, and maybe some that don't, of course. But I'm wondering where you think we can go to kind of help. And this exists again within physiotherapy and osteopathic and chiropractic, but how do we help as a profession? And I wish if we had the answer to this, man, we'd probably be running for president of our world associations around these things. But where do you think we need to go to help our respective professions start moving past these dated theories and start embracing, this more person-centered, psychologically informed, still respecting the biological components of a pain condition? Where do you think that needs to head?
I believe that we need to be more empathic with each other. And I believe that many times we believe people because we trust them. Our judgments are usually supported by what we think about that person. And in the sense of, for example, my osteopath lecturers were great people. And even when I disagree with them in a lot of things, they were top tier persons. And that's one of the things that I believe goes in favor of many osteopaths, that they are great people, that they are many times, they are people that are really trying to help as much as they can. So we need to, let's say, destroy all the ideological walls that we may have built during these decades, look each other in the eyes, and let's open an honest discussion. But I believe that for that honest discussion to have an impact, the impact that I think we should have, there needs to be some love between each other. When I say love, I say that we appreciate others, because, for example, Greg Lehman is great at this. Greg Lehman has that ability to debate about a given topic. You can disagree with him, but you are, at least that happened for me. I was like, dude, I disagree a lot with the things that he's saying, but I don't have anything against him. I respect him because he shares many of the beliefs that I have. So I'm going to try to be more open to this idea. I'm going to read more stuff about this idea. And I believe that if you can control the emotions, if you can control the emotional side, you can control the ideological or the epistemological side. If we are open to reach each other and have an honest discussion, maybe having some beers, trying to be good persons, helping good persons, because I doubt that most people doing this job is here with bad intentions. Most of the time we are maybe fooling ourselves. We are kind of trying to perpetuate the things that we recognize as ours, because it's part of our identity. What we do, if we have been doing the same things for decades, it's normal that we don't want to change. There are many on the fence that are open, or maybe they are more open to change their stuff, but they want to see really clear evidence about why things are a way or are not a certain way from people that they respect. So if we were able to, let's say, choose or convince the most prominent osteopath from the, let's say, anatomical possibilist side, and tell him, hey, could you talk with the rest of your people, or the rest of osteopaths that you know that have this similar model of reasoning, and tell them that you have changed and all these things? I'm sure that many people will follow him. The sad thing is that the people that is in power, because it's at the end, everything is about power dynamics. The people that is in power, they don't want to lose the things that put them in those places. I think that it was Max Planck who said that many times science advances one funeral at a time. Some people may need, and unfortunately, some people may need to die to change the paradigms, because they won't be able to admit or to advance. But I believe that if we want to change things, we want to do it from a place of respect, a place where we respect each other. I believe that the question is not about, the question is not about what's the truth, but how can we introduce that idea that may be more accurate in the head, in the mind of people that has a lot of things going against them accepting that fact, or that point of view.
Yeah, good points, and agree. It's tough. I think we've all probably had points in our careers where certain things that we really held tightly to or really fond of as far as interventions and way of looking at things were challenged. I spoke numerous times to some people challenging my view, some people I highly respect, and I think being able to be empathetic towards each other, we're all in this for the right things. The people I know that are practicing under these, like you mentioned with your osteopathic professors in university, they great people. I have nothing personally against that. I think we do owe it to our patients to update our understandings, especially when we see sometimes the negative consequences of getting people overly anchored in their anatomy and not anchored into their life. And sometimes stuck in a modifying structure when it's something beyond the physical structure that needs to be modified. So I wanted to thank you so much for your time. Thank you for your efforts on this paper. I really greatly enjoyed reading it. We'll link it in the show notes for you, those you are watching and listening, so you can maybe give it a good read for yourself. There's also some good responses from some folks, and it's just interesting to me. It's a good social experience. You can see some folks that reacted in a professionally critical way of the paper, and I think you all have kind of done a good job responding to that in an equally professional manner. So again, thank you so much for your time, and thank you for your work on this.
Thank you, Mark, because Anatomical Possibilism, or this piece, has been in part thanks to you, thanks to Gerard Hall, thanks to Greg Lehman, Eric Mira, and all that people. But in part, it has been thanks to you, because when I was a student and I have these kind of issues, I remember listening to many of your podcast episodes, and I experienced the struggles that you were talking about, and you helped me tremendously when it comes to being a lighthouse for my way of reasoning. And in this case, because it's about manual therapy, I wholeheartedly thank you, because you have been key for my development in this area. And I can say without a doubt that this paper wouldn't be the same if it was not thanks to you, to showing the things that you think, for putting your work out there and allowing us to pick your mind for a while.
Well, I greatly appreciate that. Those are very kind words. And the whole reason I do this, right, is to try to help people think. And as long as it's in the spirit of trying to better understand and help people in pain, which is kind of the whole mission of what we do, then I'm all in on it. So again, thank you so much for those words. And thank you all who are listening or watching on YouTube. If you're listening to this, make sure you subscribe via your podcast listening service. And if you could leave a review there, that would greatly help the podcast so we can get more of this information out. And same thing on YouTube, leave a comment, or maybe at least subscribe or pass it on to a colleague who might be struggling with some of the difficulties as far as navigating some of these topics we spoke today in practice. We'll leave it there this week. Thank you all for listening, and we'll talk to you all next week.